everyone, this is a wrap-up video for this week's topic about pain. I put pain as subjective at the top because that I think is one of the most important things to remember when we're assessing for pain, when we're seeing patients and asking about pain and going through the types of pain they have and watching how they respond to pain, because it is subjective and it's actually a very controversial topic, especially now with the opioid crisis. So we all should know about the pain scale. There's different types of pain scales, but this is the most common one we know, the 0 to 10, with 10 being the worst. Sometimes we have the face scale. I like the face scale the best because I feel like it's easy to look at and determine what your facial, that nonverbal feeling is, because it's really hard to explain to people what pain is at times. So how are we going to find out what type of pain this patient is? Well, we use our old carts. So onset, duration, location, but a very important thing to ask the patient is to describe the pain. So open-ended questions is important. So how do you describe this pain? And if you can get an idea, so you know where it is already, but if they can describe if it's sharp, if it's dull, if it's throbbing, that can help you really get a lot of information from the patient. Also, looking at verbal and nonverbal cues. And when we look at non and nonverbal cues, again, this sometimes can be a little controversial, as we looked at the discussion this week about I believe it was the patient with sickle cell. I think that was the one. But anyways, when you see somebody in pain and they tell you that they're in pain, so they say they're a 7 out of 10 and they're playing on their phone, you have to just give their word for it that they really are 7 out of 10. Now, again, everybody's different with their pain. So somebody that has really not had any health problems and then breaks their leg, their pain could be a 10 out of 10. But what if somebody was in Afghanistan in the war and has had traumatic injury already, and then they break their leg? Maybe their pain perception's a little bit different. So you have to keep that in mind. Somebody that suffers from migraines, for me as example, I can have a migraine where I'm having neurological, where my vision's going weird and pain in my head, and I can be an 8 out of 10, but I'm still driving myself to work and working. And while a lot of times I can hide it, but it is to me an 8 out of 10. Whereas when I take my medication, then I'll be like, all right, now we're down to a dull 3. So there's many people that have their own pain scale that they use. This is why a lot of times it becomes controversial, especially in settings where we're constantly seeing people come in with pain, and we have this opioid crisis where people are seeking out narcotics, which is another whole conversation, but just so we know, there is an opioid crisis, and we do need to take that seriously. There are drug seekers out there, but we have to know that there is an addiction component to that, and they need help. We are trying to look for, or need to look for, other alternatives, which is what we all discussed in the discussion board this week, whether it's acupuncture, meditation, TENS units, and nerve blocks, other modalities that we can use, which is very helpful. We've also touched on the marijuana. So right now, marijuana is a Schedule 1 drug. Until it gets off Schedule 1, we can't really get a lot of funding to do research on marijuana to see if we can find some, really well-designed control studies to put forth some evidence. But we know anecdotally that it has helped a lot of people with pain. And we do know that it is legal in a lot more states now. All right, so I want to go to page 2 here and talk about different types of pain. So this is breakthrough pain. I know we talked about this on slides, but I feel like if you get a little bit of different explanation on it, sometimes it would help. So I have this, let me just get my pen working here, get to black. Okay, breakthrough pain. So let's just say somebody has a chronic pain issue. So here, say they have chronic, let's use multiple sclerosis, and they're having a lot of leg pain. That's chronic because it's contractured at this point and they're unable to move it. So they're constantly in pain, and these people may need to be on an around-the-clock medication, such as, let's say, a patch that they're put on, or a long-acting OxyContin. All right, so this is hopefully helping, but in between they may get spikes of pain. That's breakthrough pain. That's when we're giving shorter acting medications. So whether it would be a narcotic or whether it's other modalities, like say they have a TENS unit that can help them get them through the breakthrough pain. So just to understand what breakthrough pain really is. There's other types of pain. There's referred pain, and that just means if you have pain in a certain area it can refer to somewhere else. So this is why I'll just use one example of people that have MIs. I say the chest has nerve endings that are that travel to other places. So many times it's not just chest pressure, and we know in females especially we can have different symptoms. So that's why we say, do you have left shoulder pain, arm pain, jaw pain? Do you have nausea? I had a patient that diagnosed her with gallbladder issues and acute cholecystitis and found out she was actually having an MI. Yeah, she had gallstones, but really the problem was an MI. So it was kind of scary. So that thing, I always say you need to rule out the heart before you can rule out other things. There's other types of pain, such as somatic pain, and I'll go back to my pain slide here. The somatic is more like a surface pain, so I can just use my migraines as an example. I can have a migraine, so I have perhaps some vascular stuff going on in my brain when my vessels are dilating, but also the nerve endings can reach to the skin, and if I have a bad migraine, it feels like my head is bruised just to touch it. So if you look up allodynia, it's actually surface pain. So that is a type of somatic pain. The other one is neuropathic pain. We see that in diabetics very commonly. So let me just erase this for a second here. Okay, diabetics, so commonly, and I'm not a good artist again here, so I'm just going to draw like arms and legs. Okay, so diabetics. Remember, there's too much sugar going around in their body, which we will hit in another week. But that sugar is not supposed to be in those blood vessels. I think of sugar, I explain it as like little tiny glass shards running through your bloodstream. It's damaging all those vessels, as well as nerve endings. So you have nerve endings everywhere in your body, but most often it starts damaging nerves here, in your feet, in your legs, lower extremities. And that's neuropathic pain, where it's nerves. So you have burning, tingling, and just a weird sensation of pain. Okay. All right, and then the one other thing, let's now switch over. So we talked about pain medications, alternative pain medications, but let's switch over to palliative care. So what's the difference between palliative care and hospice care? So hospice care is when they have 6 months, it's predicted to have less than 6 months to live. And hospice is, or palliative care, you can get that started at diagnosis. And sorry, it's diagonal, it's just how I write, looking at the screen, at diagnosis. But overall, it's overarching the same thing. It's pain control. Okay, pain control and comfort measures. So, if they're in pain, you give them pain medications. If they tell you their pain is an 8 out of 10, and even if the respirations may be a little low, especially here in hospice, you give the medications. Because there's really not any studies out there that show that opioids increase the dying process or expedite it. It really does not. So we need to keep these patients comfortable. So it's very similar in palliative care, although they're going through active treatment at that time. So bring us back to, let's say the patient's in the ER or inpatient setting here, and it's an acute issue or even a chronic issue. They're not in hospice or palliative care. You really do have to watch for, remember, airway, your ABCs. So you need to watch their vital signs. So oxygenation, you want to watch their respirations. But just remember the difference. Hospice kind of X-nays this out, and you want to make them comfortable. So, with that being said, I believe that's everything that I wanted to cover. But the other thing is, I want to talk about pain management real quick. We used to always send people to pain management because a lot of us healthcare providers were like, we're not dealing with chronic narcotics. And this has been going on for quite a long time. So we'd send to pain management. Well, pain management got overloaded with patients drug seeking, wanting narcotics. So pain management is really trying to change their paradigm, or they're doing a lot of education to say, no, we are not a pill mill. We are here to help you with your pain, but let's talk about some other modalities, which includes meditation, biofeedback, acupuncture, chiropractic care, as well as other things. And then one more point before I'm finished here. Let's again go back to the pain scale, how it's subjective. and it's anyone's own perception. So unfortunately, I know we can get burnt out in different settings with patients coming in and out, and they're telling you their pain is a 10 out of 10, but yet you see them doing this. Or what if all of a sudden they're sleeping when you go back in to give them their pain medication? Well, you still need to give them their pain medication because that is their subjectivity of what their perception is of what they think their pain is. So that's just lastly what I want to keep in mind. And that's it for the pain wrap-up.